So we will be covering management of severe stroke and subarachnoid hemorrhage. There's a lot of information. Years ago, there would be almost nothing to speak about. So I am going to, full disclosure, run into a little bit of the next talk, but that next talk is a little shorter, so don't worry if we're a little over time with this particular lecture. So we're going to start with a 65-year-old woman is in the hospital for severe pneumonia. She's normal at the last nursing check at noon, and when the nurse is doing the rounds, her vital signs, which were normal, was at 2:15. So think about the times, noon and 2:15. She finds the patient aphasic at 2:15 with right hemiplegia. Which of the following done immediately is most appropriate? IV heparin, MRI, MRA of the brain, a non-contrast head CT, and if negative, give IV TPA, a non-contrast head CT, and if negative, consider IA therapy or oral aspirin. Okay, good. So C is the correct answer, and it looks like pretty much everybody picked that particular answer, and we'll go into why that's the correct one as we go through the talk. So I'm going to refer you to Stroke 2013, this guidelines for early management of patients with acute ischemic stroke, for those who want the details of what we're going to cover very briefly. But the key in addressing acute management for a stroke patient is when you're thinking of ischemic stroke, we need to think about thrombolysis and then other reperfusion strategies. And then we're going to also want to know what the etiology of that stroke is and try and prevent further extension. And then we're going to watch for complications like edema, impingement, especially in the cerebellum, which we'll cover extensively, and then prevent complications. So when we address imaging, the first thing we're going to do is determine whether it's ischemic or hemorrhagic, and the very fastest way is a head CT. Ischemic stroke immediately is going to look normal like this. This is going to be an intracerebral hemorrhage. It takes TPA off the table. And then we're also going to be determining whether the extent of the swelling and effacement of other structures, and here we see that this is a well-developed stroke. And then third, when we're thinking about imaging then, is whether we can find out what caused the stroke. So if you're past the window of TPA, theoretically you want to go maybe not with the fastest, which is CT, but you might consider MRI, MRA, which is going to give you a little more information if you're past that acute window. So with ischemic stroke, that occlusion occurs, and then we have a revascularization window. We know from animal studies that initially looked about 3 hours or so, and studies had gone out to 6 hours in the European trials, and we'll talk about the 4.5 hour window in a minute. After that period of time, you start getting a leaky blood-brain barrier. So if you reperfuse late, you start having secondary problems with edema and hemorrhage. So we don't want to do it too late, and which is why we need to stay within the window. When we talk about ischemic stroke, the thing I tell ER doctors, paramedics, and patients is there's almost 2 million brain cells that are dying each minute. So even though we have a window that can go to 3, 4.5 hour window, and 6 when we're talking about other perfusion, every second is going to count, every minute counts for 1.9 million brain cells. So this is showing that the odds ratio for favorable outcome goes down as time goes on. You'll see here that the longer you go out in this time window, you're going to have less a chance of good outcome for the reasons of losing brain cells every minute. Now, you should be aware that just recently they changed the package insert. So hopefully they won't be necessarily testing you on this, the board, but from practical standpoint in 2015, we had all these criteria based on the trials previously on TPA about how you're not supposed to use it for ever having an intracerebral hemorrhage or other criteria. But now the current criteria for acute ischemic stroke is if there's a current ICH, so if they're bleeding now, if they have a subarachnoid hemorrhage, if there's active internal bleeding. Now, I put MI on the side because the package insert for MI covers the active internal bleeding. It doesn't discuss a current ICH, but you obviously wouldn't treat for MI when the patient has a bleed in their head as well. If they have a recent intracranial or intraspinal surgery or serious head trauma, that's true for acute ischemic stroke and MI. If there's any presence of an intracranial condition that the patient may be at risk for bleeding, they have a brain tumor, an AVM, or an aneurysm that you're aware of. This is also true for MI indications for TPA, and then bleeding diathesis, and then a current uncontrolled hypertension is felt to be a contraindication. You need to get that blood pressure controlled. So what about the 4.5-hour window? Now that's not in the package insert because they didn't cover that, but these are the guidelines, is that you should be thinking about all patients with acute ischemic stroke for a 4.5-hour window, except they showed that patients that were older, patients that were taking an oral anticoagulant regardless of whether their INR was correct or was out or not, and with an NIH stroke score which was very severe, 0 being normal, and then also a history of both stroke and diabetes. Those patients you probably should think twice about giving TPA at that 4.5-hour window. Now, if it's a very severe stroke, you might just talk to the family, or if the patient's able to, if it's a non-dominant stroke, talk to them about whether they want it or not, but the guidelines read these. So for an acute focal neurologic change, which when you're addressing the patient, you think, when was the last time normal? So going back to that patient, if that patient was last seen at noon, found at 2:15, certainly in the window for TPA. So you should be thinking, I saw them last normal. And in fact, the guidelines for meaningful use, which CMS is looking for, is not that you're documenting when you think the stroke happened, but when they were last seen normal. So you assess the contraindications for thrombolysis. You get stat labs if there's any reason to think the platelets might be low, the PT, PTT are out, and then make sure that the glucose is not very, very low, so less than 50, or very, very high, greater than 400, because those can mimic stroke sometimes when they're very at the extremes of glucose. And then get a stat head CT if it's acute, a CT angio if it's a large vessel event. We'll talk about that in a minute. And then otherwise think about an MR, as I mentioned before, because you're looking at etiology. We often put the head of the bed down in the very acute stage to help with perfusion. And it's funny when patients often go to CT scan, they come back better, and it's probably because their head was down for their scan. And also we get fluid going to try and help flow and make sure that they're not dry. Now, I mentioned that we're looking maybe at the CT angio, and that there actually now is literature about using stent retrievals, putting for better outcome for patients, and also sometimes for a further window out. Now, there's older devices. The Merci device were the first ones, the aspiration catheters, but these retrieval stents, the Solitor and the Trevo, now squish the clot against the wall and pull it out. And they're felt by guidelines that all the studies show that it's preferable, and the current guidelines that came out just this year, actually a month or so ago, said that if you're going to retrieve clots, it should be with a stent retrieval. So I'm going to just mention, because talking about stroke, that you should be aware that when you're looking at studies, what you want to know with the modified Rankin score is 0 to 2, and that's how most of the studies look. You'll see that there's some that are 0 to 3, but 0 being no symptoms. That's how you'd obviously like to come out of a stroke study. No disability, no significant disability at 1, but carrying on all usual activities, and then 2, that slight disability, unable to do everything you were, but still able to go after do your own affairs of activities of daily living. And then the lower ones you can see are self-explanatory, and 6 being dead. So when you look at the endovascular treatment, we just talked about those stent retrievers. What happened in 2013 at the stroke meetings was a lot of depression, because all these trials, the IMS-3 came out that said there was no benefit for endovascular therapy. It did say that still time was critical, because every 30 minutes that was delayed recovery of angiographic reperfusion, the probability of good recovery went down. But the synthesis trial out of Italy, the MR rescue that happened here in the US, all showed it wasn't superior to do endovascular. So a lot of depression, a lot of people thinking they were out of work, but 2015 has really rejuvenated this whole field. And actually there's one other trial that came out that wasn't in the slide, but it's Revascat. And the key is that just Mr. Clean came out last December, and this, if you look, is at 6-hour window, and then the patients typically got IV TPA. In the later trials, you'll see that they required IV TPA to be in the trials. And then they used stent retrieval for the most part in all of these, almost all of these patients, so 85+%. The modified Rankin scale of 0 to 2, so that area where you want to be after having a stroke, you can see what's significantly elevated in the Mr. Clean trial was 32% versus 19%. And then the ESCAPE trial, which they actually closed all these studies early, kind of based on what Mr. Clean saw and what they were seeing in their studies, but you can see 53 versus 29%, 71 versus 40%, and then further down in the 60 versus 35%. So this really tells us that we need to be evaluating patients with IV TPA, so you don't stop giving IV TPA. You get the IV TPA, and then you evaluate that patient for intra-arterial stent retrieval of that clot. So that's why we're getting the CT angio. So typically, new guidelines, and this won't be on the boards, but it's going to be important for you in practice to know that you're going to evaluate that patient for IV TPA, getting a CT. If it looks like large vessel, you'll get a CT angio and then get that patient to endovascular. And that's what the guidelines read currently, and get them to a center. Otherwise, if you don't have it, that potentially has the ability to take that clot out. So the other things we're going to cover in the medical management of stroke, the anticoagulation, which is always a big question, talking about blood pressure, hyperglycemia, and then cerebral edema, hyperthermia, and then surgery. So I'm going to refer you to Kernan's a study that came out in 2014, and not study, but guidelines in the ASA guidelines for the American Heart Association. So based on the acute stroke guidelines, after a thrombotic ischemic stroke in a 60-year-old man with hypertension and diabetes, which is the reasonable therapy immediately? Statins only if there's evidence of dyslipidemia. Acute control of systolic blood pressure less than 160. Acute IV anticoagulation, acute glucose control with a goal of less than 250, and aspirin within 48 hours of aspirin. Okay, good. So most got the aspirin within 48 hours. Most people know that statins are given for almost all stroke patients. The acute control, we'll talk about that if it's the guidelines are 180 if it's a TPA patient, or 220 if you're a non-TPA patient. The IV anticoagulation I'll cover, and then we'll talk also about glucose in a minute. So the current guidelines looking at antiplatelet agents is that we should be, and this is something again CMS is looking at, is that if you have an acute ischemic stroke patient, you're considering them for antiplatelet agents within 24 to 48 hours if that's the treatment of choice. So aspirin, or you're using aspirin in the extended release dipyridamole moiety, or clopidogrel. There's been a new change to the guidelines in that previously it was recommended, we knew that long-term use of both aspirin and clopidogrel was not useful, but more recent studies, specifically in Chinese trials, showed that if you initiate clopidogrel within 24 hours of a minor ischemic stroke, you can continue it for 21 days. It's safe at that point. There are other trials, the POINT trial, that's looking at this more, and we'll see more evidence. The key is that if you give IV TPA, you wait 24 hours after starting an antiplatelet agent, and that's just the guidelines. Now remember that if the patient had been on aspirin before and they have their stroke, don't go back to aspirin. You're going to do something else. Choose a different antiplatelet agent because the patient may have some resistance to that. Now most people aren't doing this, but I'm just going to mention in the guidelines that using an ADP receptor blocker in the acute infarct, trying to reverse the stroke, is not well established. The G2B3A inhibitors are also not recommended at this point. The trial showed bleeding with the Siximad that they had done. There's some trials ongoing. And the direct thrombin inhibitors, it's not well established using these in the acute setting. That's not for prevention. We're talking about acute setting. So most aren't using this, but just a point. Now for anticoagulation, which used to be the only reason anyone ever called a neurologist after an acute stroke, was when do you start anticoagulation? And what they've shown and have not changed in the guidelines is that the usefulness of urgent anticoagulation in patients, even with the severe stenosis of the internal carotid artery, is not well established. And the urgent anticoagulation with the goal of preventing another stroke is not recommended. So you might consider it in patients who have abnormal findings on their coagulation testing, but really a progressing stroke. So if you're calling the neurologist because the patient's having progressive symptoms, what you should be doing is getting a further workup, finding out what's occluded, what's happening, get an MRA or cerebral angiogram or a CT angio and see what exactly you're dealing with those patients. Potentially it might be interventional that you may need, or pushing the blood pressure up in someone who has a significant stenosis. Now, so for anticoagulation with acute stroke, a cerebral venous thrombosis, even in the presence of ICH, is, and that's probably a fair game question for the boards, is that if you think it's a venous thrombosis, those should be anticoagulated. I'll mention that in a minute. If you have a hypercoagulable state, you would potentially anticoagulate that patient. And in dissections now, and this is a relatively new guideline, oopsie, got that. So that if a patient has a dissection, you might think about using an antiplatelet agent or potentially anticoagulation. For cardioembolic, not for immediate anticoagulation, but we obviously think about it in patients with valvular disease, severe cardiomyopathy, and these are guidelines, the left ventricular assist device, and then atrial fibrillation within 14 days of symptoms, you might start them then on their anticoagulation. So just to come back to that concept of the cerebral venous thrombosis, there are guidelines regarding this, and what you might see in a board is a patient that comes in that may be dehydrated, often pregnant, who has a hemorrhage like this, and then if you look at the CTV, so the venous phase of the CT scan or an MRV, you can see this blockage of the sagittal sinus here. So those patients, initial anticoagulation is recommended regardless of whether you see an ICH. So that, and also for endovascular therapy to open this up can be considered, but that's only if the patient fails anticoagulation. So things that you wouldn't anticoagulate a patient acutely or you think really carefully is septic emboli. So if you saw a patient and you suspect septic emboli, probably not a question for the boards, but could be, is if it's septic emboli and you see strokes due to that, those would be someone you'd not anticoagulate. If they have extreme hypertension, you need to control that blood pressure. The key is if they have a large stroke or if they have a large hemorrhage, and even though there's an indication, you might wait a little bit, control the blood pressure, and then get it started if it's really indicated. So secondary prevention, things that we need to do after that is the hypertension control, average reduction of about 10 millimeters of mercury set by the JNC6, that the recommendations are to use ACE inhibitors and ARB, a calcium channel blocker, and usually people say, when do I start it? Usually after the first couple of days. Smoking cessation counseling, high dose, and this is that high potency statin, unless the patient's LDL is very low, those patients you might not treat. The diabetic control to keep the hemoglobin A1C less than 7, screen for obesity, nutritional assessment. The interesting thing is they actually recommend now a Mediterranean diet in patients that have had strokes, that using vegetables, fruit, whole grains, low-fat diet, poultry, fish, olive oil, and nuts. And then also this is a new recommendation, is considering sleep studies in your stroke patients. This is new. So we have now these new oral antithrombotic agents, and this is very small, but I've put it there for your reference to see, and this looked at the dabigatran, the rivaroxaban, and the apixaban. And the summary of this, and another study to look at is this particular study that came out in Lancet, and just taking and distilling all the new medications. So dabigatran, you know, direct thrombin inhibitor, so that is superior to warfarin in preventing the ischemic cerebral vascular stroke. So all others are non-inferior. For both stroke and systemic embolization, apixaban and dabigatran were superior to warfarin. So that's for both, in addition to just the ischemic stroke. Rivaroxaban and edoxaban, so these are both daily, were non-inferior. So you can see the medications given twice a day are superior. The ones given once a day are non-inferior to warfarin. But all were superior to warfarin as far as ICH. So if you don't want to bleed, any of these are the best treatment. All were associated with lower mortality, and then all were associated with more GI bleeds, so you have to be aware of that. So that's a summary of what you have out there now to treat your atrial fibrillation patients. Now, we mentioned blood pressure control early, and the reason why to wait a day or so is that 80% of the patients with blood pressures that are high you're going to see them high in the first 3 days, and then spontaneously it'll come down. It's high because they have a lot of adrenergic surge, and so we expect to see it come down. If you over-control it, the problem is that you're going to have problems with low perfusion, and if the blood pressure is too high, you're going to have edema and higher higher hemorrhagic risk. And then it's, as you would expect, a U-shaped curve for mortality. So for those that are very low blood pressure, Low blood pressure, they saw that the patients were dying with more either MIs or stroke when their blood pressures were high. They saw that there was an increase in edema and hemorrhagic risk. For sake of time, I didn't put those slides in, but there are data for that. So here's our next question. Immediately after receiving IV TPA for stroke, by guidelines, the systolic blood pressure should be maintained, and this was part of that other question, greater than 130, greater than 140, less than 220, less than 200, and less than 180. So this is after receiving IV TPA, which is okay, good. So this is the optimizing perfusion. So the guidelines are that if the patient is not a TPA candidate, you can start lowering the blood pressure about 15% during the first 24 hours. Now remember, watch it first because it may start coming down on its own, so you're really not going to be aggressive. You're going to wait to have them swallow their medications anyhow because by guidelines, we're not supposed to let patients eat until they've been evaluated for dysphagia as well. So they're not going to get their oral medications. So you'll see it come down. But if it's repetitively greater than 220 or greater than 120 diastolic, those patients you treat. Now, those numbers seem really high. Those are the current guidelines. Sometimes, depending on the patient's comorbidities, you might shoot more for like 200 or so. If they're a TPA candidate before TPA, we need to get the systolic less than 185. And it's strange, but this is how the study was, is that after getting TPA, it went from, now your goal was not 185, now it's 180. So those are arbitrary, but that's where they are right now. So less than 180 after TPA. The medications we use, labetalol, hydralazine, sometimes you may need a nicardipine. The reason why they wanted your blood pressure to be controlled and why the guidelines say if it's uncontrolled hypertension is that the concern is if you open up the blood vessel and now you have a really high risk for bleeding if you can't control the blood pressure. So as far as glucose control, for those of you who answered that higher number, that we actually want to get even tighter than the 250, that the current guidelines are reading 140 to 180. There's a new study that's ongoing to look at that in more detail, but those are the current guidelines now, is to try and get a little better control. The reason why is that when you have an ischemic bed, so less blood flow, and you have high glucose, so high substrate to that, you're now going to probably feed in more acid into the fact that you're in this anaerobic metabolism, and then you get more free radicals and also more damaging for the excitatory amino acids like NMDA receptors are activated. So avoiding hyperthermia, and for reasons that I mentioned in the next slide, we know that we should administer something to get the blood pressure, the temperature down. And you might want to be treating the infection or working up the infection, but also don't just let the patient keep spiking. The reason for this, and we don't know if we should be cooling patients, but at least normal thermia is what is recommended. We want to see that. Well, what happened to my slide there? It might be in one of my other talks, but basically I'll show you later that, and I think it's in the ICP talk, is we know that being hyperthermic, you have more free radicals and more breakdown of the blood-brain barrier. So we know that patients should be treated for high hyperthermia, but as far as hypo, we don't know. So the other thing to know is if you ever see corticosteroids now for most central nervous system problems such as spinal cord injury, which is not indicated anymore, stroke, intracerebral hemorrhage, subarachnoid hemorrhage, or ischemic stroke, as we mentioned, it's not effective. What's happening is you get cytotoxic edema when you have problems where there's damage to the brain itself. Where the steroids work is when the blood-brain barrier is leaky due to neovascularization. So if you have a tumor that's growing and have vessels growing, or you have an abscess that's growing with vessels growing, that vasogenic edema is stabilized by the steroids. So you want to use steroids in those settings, but in other settings, it's not going to be helpful. So malignant cerebral edema, there are guidelines now recommending what we should do in that in patients that have a risk for large infarct, and the people that we're going to recognize are going to have the biggest problem are obviously younger age because they have less room for swelling. If they already have nausea and vomiting when they come to symptom onset or the first few hours, and then if they have a very bad stroke by NIH scale that's much higher. So the recommendations, just distilling it, is that if you have a patient like this, and these are the ones that end up in our ICUs, right? You're worried about them. You want to keep them normal carbic. We're not going to hyperventilate them. We intubate them if they look like they have problems with their secretions. We don't have extremes, blood pressure target. We don't have extreme. We don't want the blood pressure too high. We have specific targets are not specifically set currently. Isotonic fluids, no prophylactic osmotic therapy before swelling, only if you suspect that the patient is swelling. You avoid hyperglycemia for the reasons we talked about, the normothermia, and then routine ICP monitoring is not indicated. You might consider it in certain subset of patients, and especially the intracerebral hemorrhage patients. And then seizure prophylaxis without seizures is not indicated, and those are not indicated either for subarachnoid hemorrhage patients, which are new in guidelines as well. So we don't treat them with anticonvulsants because of the cognitive changes you get. Now, for decompressive craniectomy in these patients that have a stroke that's developing, and you can see it here, and we want to open that patient up, it's a non-dominant hemisphere. We pick, it can be a dominant or non-dominant that we treat now, but the recommendations are if they're younger patients with unilateral MCA infarctions that deteriorating within the first 48 hours, those are the ones we should call the neurosurgeon and consider decompressing. Usually the thought is that you're not going to wait till they're herniated and blown a pupil, but decreasing consciousness is something we would take the patient for. And then if the patient has a cerebellar stroke, that is going to be compressing the brainstem if it's big enough. So a suboccipital craniectomy in cerebellar strokes should be undertaken as well. Let me just make one comment is that what they say is that when you're approaching the patient and the family is that you should tell them that you're not, in any way, the surgery is not going to reverse the stroke. They're still going to have their severe deficit. The question is whether the patient would want to live and survive with that stroke. And that's the question and discussion you have with them. Typically, we do that before even calling the neurosurgeon. Now, for intracerebral hemorrhage, the basal ganglia, thalamus, the cerebellum pons, and lobar, the most likely for hypertensive bleeds. Best prognosis are lobar hemorrhages. That our goals as caregivers at the bedside are try and prevent that expansion, and the best way to do that is probably blood pressure control. This is what we don't want to see, a small thalamic turn into a much larger and now deadly stroke. So these are the guidelines, and actually these are very new. This just came out. They were published, I think, they came out in May, I think were published in July. And so the blood pressure has been changed, and so one of the questions that are in our test questions here is talking about the systolic blood pressure. What used to be 160 as the goal. Current guidelines are less than 140 is considered safe. That we do want to control blood pressure to try and prevent that expansion of the hemorrhage. So the agents we talked about before, labetalol, these are the guidelines, is nicardipine. Remember, enalaprolat's out there for us, and be careful in your renal failure, watch for your angioedema. And of course, in our CNS population, we are never using nitrates, the nitroprusside or nitropase. What happens, people think they're cheap, for example, for the nitropase, but when you get patients that now complain of headache because you just put a nitrate on them, then you're going to get a scan, which makes it now an $800 nitropase patch. So it also can worsen the ICP, and you can have precipitous drops in the blood pressure. So the new oral anticoagulants, I touched on this already about the risk of intracerebral hemorrhage. I just want to mention that when you get patients like this into your ICU and you're thinking, how do I reverse this now, or how do I even find if they're on board? The key with dabigatran, which is the most difficult one to figure out whether you have it, is the studies have shown that using an eccrine clotting time is the best way to screen for the dabigatran. The next best, which most of us don't have ECT, but we probably have thrombin time available. The next best is showing that if you're looking at a dose response, here's the TT ratio here and the dose of the dabigatran. That's the next best. If you use PT, a PTT, you can have quite therapeutic levels of dabigatran and really not reflected in an elevated INR or PTT. So we would use in our trauma panel now, we added thrombin time because we don't have ECT, and in our stroke patients, we also are adding the TT to at least look for dabigatran. The patient might not be able to tell us. When you're reversing agents, you need to know your PCCs. So the current guidelines are for the factor, for some of these medications, and especially for Coumadin, we're using now PCCs. There's a 3-factor and the 4-factor, which is now available to us with the Kcentra. Remember that the 4-factor does have heparin, a little bit of heparin in it, so avoid if the patient has a history of HIT. These medications are, when you're given for treating for bleeding, does have some risk for thromboembolic events, so make sure you're giving it, and the risk outweighs the benefit when you're giving these particular medications. So just a reminder also that if you look at your INR, the fastest way to treat this, if you look at the factor 7, brings it down, but it rebounds up, and actually there's a lot of talk that you can't really reflect how much the patient is bleeding by looking at the INR when you've reversed with factor 7. If you talk to a surgeon that's been in the OR with one of these patients that you reverse with it. The guidelines are using PCC. You can see that using FFP also works a little bit slower and then has some rebound, and then of course our vitamin K takes a lot longer, but you want to get that on board as well. So the fastest way is using your PCCs. That if you look at the guidelines that come out of Britain, that the current guidelines for warfarin is that you're going to reverse these patients with the PCC, give some vitamin K as well, some FFP, and then dabigatran that you might do. And if this comes up on a board question, you would, if the patient's really bleeding and it's practical, you would probably want to get that patient to hemodialysis or hemofiltration to get it out. If it's within 2 hours, it's recommended to use charcoal in these patients. And there's some literature to suggest using factor 7 for rivaroxaban. So the ICH due to due to the vitamin K antagonist. So you're going to replate the vitamin K, and then also using the PCC as we talked about. FFP, or the factor 7 is not recommended, and then if it's ICH due to dabigatran, rivaroxaban, or apixaban, treat it with PCC. Activated charcoal, as we just talked about, and hemodialysis. These are recommendations now that came out of the newest guidelines. So if you're asked to measure what a hematoma volume is, and sometimes when you're talking to your neurosurgeon, and oftentimes I get a call from an outside hospital, when you ask them how large the hemorrhage is, they'll say big, but it doesn't help you at all. So what we do is the fastest way is, and this is too complicated math for neurologists, so simplified, it's really using A times B times C, and C being the slices divided by the width of the slices divided by 2, simplifies this equation. And let me just take this into practicality then. If we're looking at this, what we're doing is we're going to take the biggest diameter of this thing, so A, and then 90 degrees to that is B. And then you're going to look at the number of slices, so scrolling up and down on your axials, 1, 2, 3, 4. And you're going to look, and it's not on this scan, but if you look at bottom on your scans, they'll usually say like 0.5 centimeters or say 5 millimeters. You'll know what the slices are. Some places are doing 3 millimeter slices. So you have to look at what the slice is. Here it's going to be a 5 millimeter slice, so that's 4 divided by the 0.5, and then so it's going to be A times B times C, and then divided by not 3, but divided by 2, and that gives you the CCs. That's a very fast way. It gives you information to be able to tell your consultant when you're discussing how large that hemorrhage is. Now the hemorrhage is also, the size is important when we talk about prognosis, and so we want to measure it because we know that a 30 cc's gives us poor prognosis, and the Hemphill ICH score that came out looked at the larger the hemorrhage, the GCS scores. You can imagine that if you have a worsened GCS, you get a higher points, which is worse. If you have intraventricular hemorrhage, we know that's worse outcome. If it's super versus infratutorial, changes outcome in older age. And we know that the higher the score, if it's greater than 3, the mortality goes all the way up for 72%. So helpful to talk to families when you look at this as well. So this is another way of looking at this, that as your ICH score goes up, this mortality score goes up. Again, helpful information to be able to discuss with family, and this was validated in yet another trial, looking again, or multiple trials, and looking at that worsened ICH score. So calling a neurosurgeon for a stroke, we've talked about calling neurosurgeon surgery a little bit about the decompressive hemicraniectomy. So for ischemic, if there's an obstructive hydrocephalus, so there's a cerebellar stroke and your fourth ventricle is being occluded, you're going to have hydro. You don't necessarily just want the EVD. In fact, guidelines say they shouldn't put just an EVD in because they'll upward herniate because the pressure is not relieved down here and everything gets squirted up into the supratentorium. But what you want them to do is do a suboccipital craniectomy to take out that cerebellum and then relieve some of that pressure and potentially also put an EVD in. So craniectomy and hemicraniectomy. For intracerebral hemorrhage, if they have obstructive hydrocephalus from, again, cerebellar stroke or there's intraventricular blood, the guidelines read that you could consider an ICP monitor, and then again, for the cerebellar lobectomy, the suboccipital crani, you would call a neurosurgeon. The neurosurgeons for supratentorial are very fond on quoting the STITCH trial. So the STITCH trial, which was looking at spontaneous treatment of intracerebral hemorrhage, did not change mortality. So this is the Kaplan-Meier curve. So they said, well, I don't need to get out of bed for these hemorrhages anymore. And so they actually did a STITCH 2 trial, which looked at in patients without intraventricular hemorrhage, because as we saw for the ICH score, having intraventricular hemorrhage worsens outcome. So they showed that even though this looks a little different on the Kaplan-Meier curve, it was not statistically significant. So again, for supratentorial ICHs, those aren't necessarily patients that need or should absolutely have surgery, like we know that the cerebellar hemorrhages should have surgery, and it is recommended they have surgery with the ventricular drain, but that ventricular drain alone is not recommended, as I talked about. We haven't established, like we just talked about, for supratentorial hemorrhage, but I can tell you that in patients that it's very close to the surface, it can be life-saving, and we did have even a young man just last week that was 36 years old with a methamphetamine intracerebral hemorrhage very close to the surface. He would have died or been in our unit for weeks with high ACPs and a monitor in and hypertonic saline and osmotics, and instead, he was extubated after surgery. 3 days later, he's still aphasic, but he's alive and he's not in the ICU anymore. So it makes a big difference in how long we have to treat these patients. So we have to think about that. Surgeons aren't real happy about doing that, though, all the time. So effectiveness of using minimally invasive clot evacuation, which is in trial, is not yet certain, so that's in the guidelines. Now, the big question always becomes, when do you give DVT prophylaxis after ICH? Patients with ICH have should have intermittent pneumatic compression stockings beginning on that first day, but not just graduated compression stockings. These are the intermittent pneumatic compression ones. That after the patient is not bleeding anymore, they're saying that you could consider starting sub-Q low molecular weight heparin or unfractionated heparin in 1 to 4 days. So this is the guideline that they're reading. So you want to avoid the long-term anticoagulation with warfarin after they've bled. The feeling is if you've had a warfarin bleed, you shouldn't be back on that medication since there are other agents that are possibly options. And I'm not going to go through all this. You can read these for the sake of time, but it's just talking about when you can start agents. Now, I'm just going to spend a couple minutes with subarachnoid hemorrhage, that patients should have their CT scan, the blood pressure control is less than 160. We use nimodipine 60 milligrams every 4 minutes, and this is supposedly to decrease vasospasm. Some of the literature is questionable, but this is definitely in the guidelines. Maintain euvolemia, treat agitation and pain, because that's going to maybe have them rupture their aneurysm again, so that's an important thing to do. Now, urgent neurosurgery and endovascular evaluation by an interventionalist for securing the aneurysm, and the surgeon is also for hydrocephalus. I'm just going to mention a little bit about some of the complications. It's important to recognize that this, when you see a lot of blood at the base of the brain, is typically aneurysmal. If you see it over the convexities, it's more likely traumatic. A lot of symptoms, we talked about getting the CT scan. If you're not sure what's going on, if you obviously have blood at the subarachnoid space, you don't need to do an LP. It's just if the patient has questionable history and the CT is negative. A CT angio can be very helpful. And then you have to think about if you don't see an aneurysm, they may have a perimesencephalic benign subarachnoid. They need re-imaging. Treatment, we all know, is either with aneurysmal clipping or now coiling. Typically, it used to be in the older patients, but now a lot of patients are going straight to endovascular. Surgeons are less interested in doing clipping. And what we're doing with the clipping is trying to prevent the rebleeding. So it's 4% rebleed on that first day, and then 1.5% in the following days. There's now, the guidelines are, if you're taking the patient in transport for a long time, it's going to take a while to get to your center, that you should be thinking about using the aminocaproic acid to try and prevent the patient from rebleeding. It used to not be recommended because it seemed to be associated with more delayed ischemic events, but it's really for just that short course. You don't continue it after that, after the patient gets to you and secured. We want to control the blood pressure, systolic less than 160, and analgesia, as I mentioned. What we worry about is the vasospasm, and that's what the nimodipine is supposed to prevent, where the patient goes and starts having strokes here as delayed ischemic events. We can open these up, but the treatment, we're not quite sure what causes it. The treatment is going to be fluid resuscitation and HHT. In these patients, it happens in about 30% of patients. We make the diagnosis mostly from the clinical findings. TCDs can be helpful, and then radiographic by doing CT angio. So we use the nimodipine. They're doing trials in clot removal. The volume expansion is really based on this premise of the flow. So whenever I'm teaching about this, what you're trying to do is get flow up, so it's pressure, and then the radius of the vessel, which we may treat by using angioplasty and also intraarterial nicardipine. But then the viscosity and we can't change the length of the tube, but we can change viscosity by keeping the patient hypervolemic, and also the blood pressure is that the major P here is keeping the blood pressure up to keep that flow in. So that's our HHT, or the hypertensive hypervolemic therapy that we use in patients. We need to be worried about hydrocephalus, looking clinically for altered mental status, getting the imaging, and then get the surgeon there to try and to put a ventriculostomy, and sometimes they need long-term VP shunting. So the next question is, what is the following most likely cause of hyponatremia in a patient with subarachnoid hemorrhage? Congestive heart failure, cirrhosis, associated polycystic kidney disease, SIDH, or cerebral salt wasting? Okay, good. So cerebral salt wasting. So what this is a lot of people picked SIDH, and cerebral salt wasting is a known entity now where having a subarachnoid hemorrhage causes this atrionatriuretic peptide, or brain natriuretic peptide that's now found, comes out and causes you to lose salt in water. Those patients are usually hypovolemic because they've lost fluid, and SIDH is euvolemic. We don't want to let their sodium get too low because you have cerebral edema, and we replace them with 3%. So what we know about cerebral salt wasting and SIDH in this table is showing that really the differential is the plasma volume, which is low in the cerebral salt wasting and normal here in SIDH. The reason why the ADH is high in some of these patients is that as their volume status gets low with the cerebral salt wasting, ADH kicks in. So it's actually trying to treat the fact that you're a low volume status. When people were fluid restricted, thinking they had SIDH back in 1985, what they found was that when you fluid restricted them, they ended up having cerebral infarction for the reasons we talked about with vasospasm. So if it appears in a board question about a subarachnoid hemorrhage with low sodium, do not choose that you're going to fluid restrict this patient. You're going to want to replace fluid in them. Even if it might be an SIDH, you really want to give them the sodium and bring that salt up with the sodium up with salt-containing solutions. Now, the other thing to be aware of is the myocardial ischemia that we know that you have this coagulative necrosis, but with intracerebral injury, we have this thing called myofibrillar degeneration, which is also known as contraction band necrosis, based on the fact that they're seeing that the muscles are dying in sort of this hypercontracted state. So you see these transverse eosinophilic bands that are associated with subarachnoid head trauma, and seen in all these, even intracerebral hemorrhage near drowning, and first described in patients with pheochromocytoma. So the thought is that this is an adrenergic associated event, that what happens is that there's stimulation of the hypothalamus and then sympathetic stimulation to the heart with sudden calcium efflux influx and efflux of potassium. This happens in the subendocardium where the conduction system runs, so you have to watch for arrhythmias in these patients. So this has been known as stunned myocardium and Takotsubo's cardiomyopathy. So those are the arrhythmias that we see. You can see EKG changes that are noted here, and now is seen and described as Takotsubo's more recently in the 2005. So we see this associated with subarachnoid. We need to follow these patients for arrhythmias and just support them. Usually in about a month or so, their echo comes back with normalized EF. With seizures in subarachnoid patients, happens at about 6% of the time. We may need to treat these patients, but the key is that the guidelines are that you don't prophylax now unless they actually have a seizure. For this reason, you have cognitive disability after subarachnoid hemorrhage, so it's not recommended. So the final thing is just their sudden death occurs, but in these patients, about 58% will have premorbid return for function. Not all of them do, and it's important to know when you're talking again to families that we grade these by the Hunt and Hess grading, and that as the Hunt and Hess gets worse, so altered mental status being 3 and higher, worse prognosis as far as mortality goes. So thank you.